Welcome all and good evening to all of you. We are now doing the PG Ophthalmology PG classroom. This is the 9th edition, and we have with us today two eminent professors, Professor Natasha Radhakrishnan, who is a professor of ophthalmology at Amrita Institute of Medical Sciences. She's a vitreoretinal consultant, and Dr. Karthikeyan, who is the professor at Government Medical College, Coimbatore. Welcome to both of you. And we have today children from Amrita Institute of Medical Sciences presenting on OCT images. So this whole class is on interpretation of OCT. And without much ado, let us just start with Dr. Natasha's presentation on how to simplify evaluation of an OCT. After this 15 minutes talk, we will go to some 15 OCT images, which will take us through the different nuances of OCT interpretation. Over to you, Dr. Natasha.
Thank you, Dr. Gopal and KSOS for this opportunity. Good evening to all. I hope you will all benefit from this presentation. I'll try to keep it as simple as possible. So the basic interpretation of an OCT, how do I read an OCT, is what I'm going to deal with today. So OCT, as you all know, is a non-invasive transpupillary imaging technology for evaluation of retinal structures. It gives you two kinds of information: qualitative information regarding the morphology, structure, and reflectivity, and quantitative information, dimensions, topography, thickness, and volume. The testing options in any OCT are the macular cubes, the high-definition 5-line raster, the optic nerve head cube, anterior segment cube, anterior segment 5-line raster. I have no financial interest in this presentation, but my images are all from the Zeiss OCT. And mostly we will be dealing with today with the macular OCT interpretation and not with the optic nerve head. The macular cube generates a cube of data through a 6 mm square grid by acquiring a series of 128 horizontal scan lines, each composed of 512 A scans. And there is a macular cube 200 into 200 as well, but that has less resolution compared to the 512 into 128. This is what a macular cube screen will look like. And you can see the area that you're screening on the left down corner. And you can see each scan as it is done on the other side. And this is how a printout will look like. It will have both the line scan there as well as the volumetric data on the right side. The 5-line raster, this gives the greatest image quality. It creates 5 parallel scans of equal length. The line, length, spacing, and rotation of each are adjustable. For example, this is right through the fovea. And if you want in a point of interest anywhere above or below the fovea or above the optic disc, you can do it in that area also. You can shift the raster there and do it, and that will give you a high resolution scan through your point of interest. And again, we can get the dimensions, volumetric data also from it. 3D surface maps can be done, the machine itself will provide the 3D surface maps to you. Once you have done that, you can also have your result as a 3D video, which is of more use when you are going to demonstrate it to a patient. The image, what you're seeing, is displayed using a false color map. It has nothing to do with the correct color of the retina. It corresponds to detected backscattered light levels. It can also be displayed as a grayscale. The maximum intensity signal is displayed as white in gray and red in the false color scale. And the weakest intensity is black and blue. The grayscale, the slight variations in intensity can be easily picked up on a grayscale. So most of us like to interpret the OCT using the grayscale lesions, and subtle lesions are less likely to be missed. But the color scale gives a higher contrast, which is useful in some cases. So you all know the normal retinal architecture. So I'll not go into that, but you should remember the normal retinal architecture when you are interpreting an OCT, because the OCT is like a histological section across the point of where you're scanning. And therefore, you at the fovea, these are the layers that you can see. Almost all the layers that you saw in the previous picture are now seen clearly in the OCT itself, if it is a very good resolution and very clear media. From the choriocapillaris Brooks membrane complex all the way up to the internal limiting membrane and the vitreous can be seen. Now, let me draw your attention to the rods and cones. And here and lower down, you can see something called the outer segment, inner segment junction. This one is also seen as a line in the OCT, which is of particular interest to us retinal surgeons. And we'll see how that looks like in the scan. So here you have the interdigitation zone or the ISOS junction, and the interdigitation zone, and just above that the ellipsoid zone or the ISOS junction that comes just below the external limiting membrane. Now, what is a good scan? A good scan, the fundus image should be focused, should be sharp and clear. The scan overlay should be centered at the point of interest and should have uniform illumination. The scan itself should be complete in all the windows without missing data, and the color density should be the same from end to end, and signal strength ideally should be 6 or greater. And we should learn to recognize artifacts as well. What you're seeing on the right side as a break, as if there is a retinal break, is actually a movement artifact because of movement of the patient's eye. If it's a well-centered scan, and if it is here, you can see that the scan is quite clear, but the point of interest is not clear because the part of the camera is not very clear. Now let's go to reading an OCT. So you have to read a line scan, a macular cube, 3D analysis, change analysis, and there is also EDI and UNFAS OCT. The line scan on the HD raster is best to give you the morphology, structure, and reflectivity. The morphology is the overall retinal concavity or convexity. For example, here you can see that there is a dipping down of the retina, which signifies that there's some amount of staphylomatous change. Otherwise, it will be a straight where you are seeing the retina. The retinal, the interface deformation, you can see here, the vitreoretinal tractions, holes, pseudo holes, and retinal folds are what we have to see first. So here you can see there is the interface is not correct. You can see that there is some amount of traction happening from the vitreous. Again, this is another area where the vitreoretinal interface is abnormal. We will go into all these abnormal findings later on as we do the case presentations. Pigment epithelium and outer retinal abnormality, you can see neurosensory detachments, pigment epithelial detachments, drusen, subretinal cysts. So this is you can see the drusen as well as the neurosensory detachment. Here you can see a PED. Then you have to look at the structure. What are the alterations in structure that can happen? You can have edema, atrophy, scarring. These three changes can be either in the overall retina, or it can be in the inner retina or in the outer retina, depending on what is the cause. So you can have, like in this picture, all the layers of the retina being involved, or you can have just the inner layer being involved, as in the Scheitic picture. And you can have barrier structure alteration. So what are our barrier structures that we are looking at? The internal limiting membrane, the ISOS junction, and the retinal pigment epithelium. This can be disrupted, it can be fragmented, or it can be deformed. So disruption, fragmentation, deformation of the barrier structures also should be taken into account. Here you can see that the retinal pigment epithelium here is deformed. Now, high reflectivity membranes. What are the high reflectivity membranes? When you're looking at reflectivity, you can have high reflectivity things as well as low reflectivity things. The high reflectivity findings are in epiretinal membranes, deposits, and hemorrhages, and the low reflectivity are cavities. So here you can see that the epiretinal membrane there up above the fovea is highly reflective, and here you can see hard exudates are highly reflective, and you can also see that in between you can see areas of low reflectivity, which are actually the cystoid spaces. Shadowing effect. What all can produce shadowing effect? Normal retinal vessels can produce shadowing effect that can easily be mistaken to be an abnormality. Hard exudates produce shadowing. Hemorrhages produce shadowing in the inner retina. In the outer retina, scars, RP atrophy, and sub-RP hemorrhage is what causes usually shadowing. Now you look at this picture. Here you can see that actually what you're seeing here as a shadowing is the scan that is across the blood vessel. So that is the shadowing effect of a normal blood vessel. And here hard exudates also, clumping of the hard exudates is producing a shadowing effect. Here you can see you cannot see the underlying structures. You can't see the choroid clearly. That is because there is a sub-RP hemorrhage. Now, loss of structure in which you cannot make out the layers. So chronic retinal diseases, especially DME or CNVM that have been treated, will cause loss of structure. Sometimes you can get severe hyperreflectivity and loss of structure, and that is usually seen when there is an arterial occlusion, cloudy swelling of the retina. Now, interpreting a line image, you have to speak about the posterior vitreous surface, the vitreoretinal surface, the neurosensory retinal layers, ISOS junction or ellipsoid zone, and the retinal pigment epithelium. The posterior vitreous face is a thin curved horizontal line of hyperreflectivity that is just visible anterior to the retinal surface. It will not be visible if the vitreous is still attached well or detached completely beyond the area that is visualized by the OCT. Now, this is a small vitreomacular adhesion that you can see here. Here, however, the adhesion has now separated and it is a posterior vitreous detachment. Vitreoretinal interface abnormalities can be epiretinal membrane, which can then cause alteration of foveal contour. In the neurosensory retinal layers, you have to look at the thickness, regularity, and continuity of the layers. ISOS junction, again, you're going to look at disruption and continuity. Retinal pigment epithelium for variation in thickness, fluid above or below, discontinuity, and areas of elevation. Quantitative analysis, we get linear dimensions, thickness, volume measurements, and topography. These are the linear dimensions, especially for pigment epithelial detachment. You can actually measure using the caliper and the machine. And volumetric data, you will get the quantitative data regarding the thickness of the retina from the scan itself. You do not have to do it manually. The ganglion cell thickness is also given to you by the machine, and you can actually see the ganglion cell thickness in each quadrant. 3D visualization, of course, is also possible. And this is the change when you have done a scan before and you see it again. You can see how much has increased or decreased, but it is important for the person who is doing it to see that it is fairly centered in the same area. Otherwise, you can misinterpret it very easily. So how do you report an OCT? After all this, you have to look at the reliability. If it is poor, add a note on why. You should write both the qualitative and the quantitative data there. Any change from the last scan, any other significant features, and the OCT diagnosis. What should you not do? Do not interpret OCT images without clinical history and proper examination of the fundus. At least have a fundus image for comparison, and do not interpret OCT images in parts. You should have the raster through the area of the interest, the macular cube, and the previous OCT images if you need to comment meaningfully on an OCT. So finally, imaging is not an exact science, so clinical correlation is extremely important when you want to make a proper interpretation. So with that, we come to the end of the presentation on how to read a OCT. And I would just like to do a small, just to let you know, tell you some things about something that is of great interest to retinal surgeons now, which is called OCT biomarkers. So now what are biomarkers? They are just OCT findings that will allow us to prognosticate a particular case. So biomarkers have been studied in many retinal diseases, mainly in diabetic macular edema, in venous occlusions, and in neovascular membrane. We have no randomized control trials or any long-term trials on these, but we have some information from various sub-trials and also from published data from many workers. So in diabetic macular edema, the usual the biomarkers that we are looking at are usually subretinal fluid or submacular detachment, cystoid changes in the outer nuclear layer, presence of cystoid changes in the inner nuclear layer, continuity of that inner segment, outer segment layer we talked about before, ISOS junction, hyperreflective foci. Now, these are not hard exudates, but they are tiny hyperreflective dots that you see in diabetic macular edema, and they are supposed to have prognostic importance. Status of the vitreomacular interface, presence of an epiretinal membrane, disruption of the inner retinal layers called drill, the presence of it and the extent of it, and also something called a cone outer segment tip line, whether it is intact or disrupted. Of course, this is of, you can see here these lines that I'm talking about. The ISOS junction is here just below the your external limiting membrane, and even below that is your cone outer segment tip line. This cost line is supposed to be now gaining more importance in prognostication than the ISOS junction. And these are our other findings. The drill means you cannot make out the retinal layer separately in the inner retina, and that is called the disruption of retinal inner layers. This is disruption of the cost line. Here you can see large cystoid space, and these tiny dots which do not correspond to hard exudates are called hyperreflective foci, and the number and the extent of hyperreflective foci also have importance in prognostication. In C and VM, central foveal thickness, intraretinal fluid, intraretinal cysts, again hyperreflective foci, ellipsoid zone integrity, subretinal fluid, and PEDs have been studied, the height and the extent of the PEDs. I will not go into the details. I'll just show you what we are looking at. Central foveal thickness is measured from the ILM to the fovea, from the ILM to the Bruch's membrane at the fovea with the help of the inbuilt calipers. The intraretinal fluid is an optically empty area that is confined to the inner retina. The intraretinal cysts, which are of two types, degenerative and exudative. These are the intraretinal cysts. The subretinal fluid is, of course, an optically empty area that is directly internal to the retinal pigment epithelium Bruch's membrane complex, but lies external to the outer limiting membrane. The HRF, small hyperreflective particles that are scattered through the retinal layers formed. Here you can see that it may be under the the neurosensory detachment. It may not be scattered in the retina as it is in DME. There are different types of hyperreflective foci. Then, of course, the size and the type of the PED. So you can have serous PEDs, you can have fibrovascular PEDs, the height can be measured, the ellipsoid zone integrity. So all these biomarkers are of importance in various conditions, and we should learn to identify them and learn about the importance of each of these in various conditions. With that, we come to the end of my presentation. Let's go to our postgraduates and see whether we can look at some cases. Thank you.
Thank you very much, Natasha, for that enlightening presentation. So before we start, we will have some opinion by Karthikeyan, sir. Sir, can you come in?
Yeah, it was a detailed description about the madam about
your video is off, sir. I think your video is off. Yeah. Thank you.
Yeah, some few points about angio-OCT from ma'am. Can ma'am add any new points about angio-OCT?
I've confined my talk to the usual high definition OCT, sir. OCT angio. I think the cases are also confined to that. We have not taken that up for discussion.
So Octa basically takes into consideration the RBC mobility. And so when the RBC is mobile within the vessels or within the tissue, so that reflectivity gives rise to changes. Whereas a pure SD OCT, the spectral domain OCT or the subsource OCT is about a B scan which is generated by the laser. Whereas here the traveling of the RBCs give rise to different signals, and these are picked up and amplified, and artificially a vascular net is created. So that is how OCT angiography works. And currently OCT angiography is significantly in use, and but it has not reached a decision-making purpose. So it is into research, and a lot of us are using these OCT angiographies to actually look at the new vessel formation, progression of new vessels, especially in choroidal neovascular, in a lot of diseases, in which we are getting a lot of insight into the disease process and pathology and etiopathic vessels. But it is not
be replacement for an FFA, sir? Can it?
It cannot be a complete replacement for an FFA. One thing is that OCT generally, most machines are confined to the posterior probe, whereas fluorescent can give you peripheral pictures as well. That is point number one. Point number two is, we cannot pick up leakage of a vessel. So leakage can only be picked up on a fluorescent angiography. You can pick up ischemia, you can pick up capillary loss, but you cannot actually pick up leakage. So in conditions in which you are looking for leakage, looking for inflammation, there could be surrogate markers with the Octa, but it is not going to completely replace. But now newer machines have come up with wide field OCT right till the ora serratum. So they have come in, and newer other adaptive optics. A lot of newer attachments are coming in which we can see cells with more magnification, more precision, and functionally mapping them. So I think imaging in ophthalmology is going to be a sea change every 5 years or so, and we will see that change come into clinical decision making as well. But currently, decision making based on spectral domain or subsource OCT is what is done. Okay, can we have the presentation, Netra?
Yeah, sure.
Netra, you are muted.
Yes, sir.
Yeah. You can make it full screen as well,
I'll start, sir.
please.
This is an
Dr. Natasha and Dr. Karthikeyan, please feel free to ask questions.
This
Netra, it's
is-
all yours.
This is the OCT showing a hyperreflective layer on top of the retina with alteration in the foveal contour with mild thickening of the inner retinal layer with formation of a pseudo hole, macular pseudo hole. So according to Wang et al. Classification, OCT based classification, it would fall under the category 2A, which is a fovea sparing ERM.
Okay, very good. So we are looking at the left eye of this person, and there is probably this patient, when you clinically examine it, will look like a macular hole on a 90 diopter or ocular imaging measure a macular hole, like it will be significantly red. On clinical examination, yes, there is no PVD here. PVD is here? Yes or no?
No, sir.
You are not able to see the
See the
You're not,
PVD.
it's not
So,
visible on.
see, in an epiretinal membrane, usually macular schisis not macular schisis, the vitreoschisis or PVD would already be there, and that vitreous may be significantly elevated. So we will not be able to capture it here in this small area. This is only some 1,000 microns here from the retina to the top of the scan. It's only 1,000 microns probably. Okay, so this may be beyond that. Okay, then we have thick hyperreflective membrane, which is not involving the fovea, right?
Yes.
But which is exerting traction on the parafoveal area both sides. The most important thing here is that the outer layers are how do you talk about the outer layers here?
Thickened.
Outer retinal layers? They are
Thickened.
no outer retinal.
Outer retinal layers.
Yeah.
Retinal layers are
Outer retinal layers means which layers? The retinal pigment epithelium, ISO essential. Yeah, those are the outer retinal layers.
They're all
They're all intact.
intact.
Okay, they're all intact. So what does that mean?
This
Visual prognosis.
your
Visual prognosis is very good. It's not about visual prognosis. First, we have to decide on whether to do surgery or not. Okay, this particular macular epiretinal membrane may have a vision of 6/6 parts, and the patient may be asymptomatic. And in such a case, we may not operate also. All right, we may not operate also. But if vision drops and if the macular morphology keeps on getting altering, and we are keeping this patient under follow-up, then definitely yes, we will consider surgery. But if you are considering surgery, the prognosis is excellent. Any other point that you have to add, Natasha or Karthikeyan sir?
What is the ophthalmoscopic test that can distinguish this from a full thickness macular hole?
Or a slit lamp based 90D based test also you can do.
Yeah, you can do it on 90D also.
and optic.
It starts with the W.
Either you can use a direct ophthalmoscope or you can use the slit lamp biomicroscopy. What is the test called? Anybody? Or the sign? Okay, it's called the Vatsky-Allen. Yes, it's the Vatsky-Allen sign, where if it's a full thickness macular hole, the patient will be able to appreciate a break. You put a slit beam across that area at the fovea. It's very nicely, you can do it with your direct ophthalmoscope. And then the patient will be appreciating a break in that line. But here the patient will not appreciate a break because the outer layers are quite intact. Shall we move on?
Sure. So you were telling about the classification of no, you can go to the next case. You are talking about the classification. Can you tell me more about the classification of epiretinal membranes or vitreomacular adhesions, Netra?
So epiretinal membrane, it was given by Wang et al. OCT-based classification, where 1A will be outer, there will be an outer retinal thickening with a mild inner retinal thickening. 1B will be outer retinal thickening with an inward projection with again mild inner retinal thickening. And 1C will be prominent inner retinal thickening. All these will be fovea involving ERMs, and later will be fovea sparing ERMs will be 2A, 2B. 2A will be formation of a pseudomacular hole, and 2B will be retinoschisis with splitting of the retinal layers.
Okay, so you mean to say that it starts with outer retinal thickening, is it?
Yes, sir.
Outer retina generally does not get thickened. You must
Minimal.
be. Outer retina is the layer of the rods and the cones and the retinal pigment epithelium, etc. That doesn't get affected in an epiretinal membrane. Only late, very late degenerations occur in the outer retina when the epiretinal membrane has been there for a long period of time. Okay. So, okay, can you come to this particular photo? This is the.
This OCT is showing a hyperreflective membrane on the surface of the retina with there's a cyst at the level of the fovea, showing a mild alteration in the foveal contour with mild thickening of the inner retinal layers. So according to the classification, it should be around 1B.
Okay, again, yeah, Natasha.
No, here you can see that the cyst has involved a bit of the outer retina also, but otherwise, usually the inner retina is more involved.
Okay, here the epiretinal membrane has not significantly changed the macular morphology. The contour of the macula is almost preserved. But only thing is, there is a cyst which is developed there, which signifies that this may have been a long-standing epiretinal membrane. So whenever there is a long-standing epiretinal membrane, there will be more damage. And even outer retina may show damage in a long-standing epiretinal membrane. That is why the ISOS junction may show abnormality. The outer layers of the cones and rods and all may show. So visual prognosis in such cases are a little less optimal than in the last case that you showed.
And we should keep in mind that it may be a primary retinal pathology there as well, some long-standing old vein occlusion that has caused edema to be there for some time, and then the epiretinal membrane has formed on top of that. So, because the architecture seems quite disrupted.
Yeah. So Netra, can you just tell us about the etiology of epiretinal membranes? What are the causes in which epiretinal membranes will be?
Epiretinal membrane can occur following any PRPs, follow any retinal surgeries. It can also occur following retinal vein occlusions or long-standing edema following retinal vein occlusions, retinal artery occlusions, or diabetic macular edemas. Can also be.
Can we classify? Can you just classify it nicely?
It can be either primary as not associated with any other retinal conditions.
Yeah, and the most common risk factor for that is senile, isn't it? Age-related.
Age-related.
Age-related as well as PVD.
Yeah.
So PVD may cause some micro trauma onto the superficial layers of the retina, and that can cause it.
So that is primary.
Retinal tear or peripheral hole that can cause a release of the glial cells into the glial cells or retinal pigment epithelial cells into the macula, and that can transform into epiretinal. And one thing I want to comment here, Netra, when you were asked what are the causes of epiretinal membrane, the first two things that you rattled out was panretinal photocoagulation and retinal surgery. Okay, that is a psychological problem that we have. Okay, so whenever I ask a patient about whenever I ask a student about something, they will tell me, okay, it is post-surgical complications. See, take it out of your mind that post-surgery. First, talk about things that de novo occur. Pathologies do occur in people. Okay, so think about those pathologies first, and then tell about wrong IOL, wrong cataract surgery, wrong this thing, wrong that thing. Okay, so first is primary pathologies. All right.
Then it's further classified into inflammatory causes, vascular causes, degenerative causes. Degenerative condition which can cause epiretinal membrane cellophane maculopathy. Retinitis pigmentosa. So all of these causes vascular pathologies, other inflammatory conditions, like even uveitis, long-standing uveitis with cystoid macular edema can end up getting an epiretinal membrane. So that is how it is classified. So basically into idiopathic and then secondary.
The next case.
This is the OCT of the right eye showing a vitreomacular adhesion with a normal foveal contour. So the reason why I'm calling it a vitreomacular adhesion is because there's only partial vitreous detachment and there is an elevation of the cortical vitreous above the retinal surface. And there is within the central 3 mm of the fovea, there is still persisting attachment is still there. And in a vitreomacular adhesion, there will not be any changes in the foveal contour, whereas compared to vitreomacular traction, where there will be changes in the foveal contour. And there's also an acute angle between the inner retinal surface and the posterior hyaloid, which will be seen both in VMA and in VMTs. So because of this, this would be a VMA.
Any classification of VMA? No.
VMA.
It could be focal, it could be
focal or broad based within less than 1500 microns, and if it's more than 1500 microns, then it will be broad based.
Okay.
And again, primary or secondary.
But there is no traction. Okay. All right. It's just a touch. Fine. Next.
So this is a vitreomacular traction with alteration in the foveal contour. So this is again called vitreomacular traction for the same points as vitreomacular adhesion, along with changes in the foveal contour because of presence of a pseudocyst, or there is an elevation of the fovea from the RP. So that is why this is a vitreomacular traction, and usually there's an absence of a full thickness interruption of all the layers. So if there's an absence of full thickness, if it's all the layers are involved, then it will become a macular hole. So there is absence of interruption of the all the layers, and this again will be broad-based or focal. Focal will be less than 1500 microns, and broad-based will be more than 1500 microns.
Okay. So this is a case in which the outer retina has given way. Okay. And one important thing, this type of lesion will require surgery because the patient will be usually complaining of either metamorphopsia or decrease of vision. Right.
What is the importance of seeing this kind of picture in diabetic macular edema? This is one type of diabetic macular edema that you will not treat with
intravitreal injections.
So intravitreal injections should not be given if your patient with DME is having vitreomacular traction. It has to be treated with surgery.
During surgery, one important thing is that, there's a very thin roof of that particular vitreomacular traction, the very thin roof. So if you just pull on the vitreous and cause a PVD to be off, that roof can be de-roofed, which means it will form a hole. Okay, so we have to carefully trim around this particular area of traction so that maybe a bit of that tissue can remain on either side of it without an attachment with the rest of the vitreous. So we can just cut around it. And then what happens is you can do a ILM. Then you can do an ILM. So ILM peeling ensures that you've completely removed all the traction. And again, during the ILM peeling also, maybe you need not, completely peel the ILM onto the surface of that roof. Okay.
This is the OCT of the right eye showing a full thickness macular hole with vitreous separation. So according to gas classification, this will be grade 4 because it has full thickness macular hole with complete vitreous separation.
Can you tell us the gas classification?
Gas classification is classified as 1A, where there will just be a yellow spot with a foveal depression and there's no vitreous separation. 1B will be a yellow ring with normal foveal contour and no vitreous separation. And 2 will be small full thickness macular hole less than 400 microns. And 3 will be full thickness macular hole more than 400 microns, but there will not be a full vitreous separation. And 4 will be where there's full thickness macular hole with complete vitreous separation.
And is it an OCT based classification?
It is not an OCT based classification.
So it's an ophthalmoscopic classification, isn't it? Pre-OCT classification.
But you should understand the greatness of gas, that before the era of OCT, with the 90D, whatever classification he gave, even now stands the test of time with the most modern OCTs. Okay. Is there any OCT-based classification on macular holes? No, it's almost the same, right?
Same. Can you tell us a little bit about the pathology, why it occurs? The basic pathology of a macular hole. So everybody gets PVD, isn't it? So everybody gets PVD, but only some people develop macular holes. Anybody?
When the PVD is the complete vitreous attachment causing the vitreous to.
So it's not like a retinal tear, isn't it? Normally, when you have a PVD and you have traction, there is a retinal tear. But that is not the thing that is happening here. It is a splitting of the retina or a separation of the retina. So what kind of traction should be there for that?
Tangential traction.
That word? Tangential traction, exactly. So it's because of a tangential traction that is developing at the fovea that this splitting of the retina occurs and the macular hole occurs.
Okay.
So anybody, how can you predict a good prognosis, prognostic factors in macular hole surgery?
Based on minimum linear diameter, basal diameter, macular hole height, macular hole index, diameter hole index, tractional hole index. So each of them have to be measured. So macular hole index is the maximum height of the macular hole divided by the maximum diameter of the macular hole. Diameter hole index is the minimum diameter of the macular hole by the maximum diameter of the macular hole. Tractional hole index is the maximum height by the minimum diameter. And the minimum linear diameter is the distance between the inner parts of the macular hole, and the base diameter is the diameter at the level of the RP, is how you will measure the base diameter. And the height of the macular hole is the distance from the RP to the innermost aspect of the macular hole. So
very good, very good.
All based on all this is how you can prognosticate the after surgery.
Can you tell me which are the bad prognosis, which are the good prognosis?
If base is more than a height, then it's a bad prognosis.
Okay, very good.
Okay.
Which means a flat, large macular hole is a bad prognosis for progression. If there is more traction like this, you can actually remove the tangential traction and the hole will close like this. Okay.
And clinically, one thing that we look at is the duration of the vision loss. So the longer the duration, the lesser likely that the vision will recover well after surgery.
Yeah, the newer additions to macular hole surgery. See, what are the steps of macular hole surgery? One is complete PVD, removal of the vitreous. You don't have to do a vitreous base excision, where you can just trim the vitreous till the equator. Then you do internal limiting membrane, internal limiting peeling, ILM peeling, and then put gas. The newer additions to macular hole surgery is one, OCT enhanced macular hole surgery. So you can have an intraoperative OCT which looks at it. Okay. Number two, you can look at an autologous retinal graft, especially in a very large macular hole. You can take a macular graft, or we can take a retinal graft from some other patient, maybe supranasal patient, and put it on top of the macula, which gives it more functional equity. Like an old macular hole, like Natasha said, 2/60, 3-year-old macular hole. The usual macular hole surgery does not give any, functional prognosis. But a retinal graft can actually give rise to better prognosis. Maybe the vision may improve to 6/60, 6/36.
Macular hole is like an omelette to a chef, to a retinal surgeon. They stuff all sorts of things into it. They will stuff the ILM into it. They will stuff serum into it, right?
Now, very rapidly, any peripheral tear, optic nerve pit, any hole that is there, we will stuff. We are stuffers. All right, let's move on.
So this is a clinical picture of the right eye showing a scar at the macula, and left eye is also showing deciform scar at the macula. Move on to the OCT picture, Nitra. So OCT of the right eye, there is a VMA, foveal contour is lost. There is an intraretinal fluid with a large PED at the center, and RP irregularity is there, and there is hyperreflectivity at the center of the fovea.
What is the overall morphology?
Yes, ma'am.
The overall morphology of the retina is altered, no? You're
Yes,
getting
ma'am.
a
Yes,
convexity there, isn't it? So there is a convexity because the entire retina is elevated under the
Yes,
RP. So then what else are you seeing in the other eye? And
So
what about
primarily,
the?
it is a type 1 choroidal neovascular membrane with a large pigment epithelial detachment, which probably has stayed on for a long period of time. And that is why the scarring is there. That is why the intraretinal fluid is there. And that's why the RPE scarring is there. Okay. But in the left eye, you said it is a disciform scar. It is not a disciform scar. Can you come to the last picture, clinical picture? It is not a disciform scar. Disciform scar would be a round scar. Something in the right eye, you can say probably it's looking like a disciform. It's going to become a disciform scar. Disciform scar occurs only after it bleeds. And when it bleeds and then it scars, then it typically forms a disciform scar. Here you can see that the central area is still central, the left eye, the central retina is still, most of the retina is looking viable. And temporal most extreme is there is a scar definitely. Probably there was a subretinal bead or an RP rip, which must have caused a curvilinear, very regular curvilinear opening like that. Okay, now come to the OCT.
So OCT of the left eye foveal contour looks okay. There is a large hyperreflectivity at the temporally with clumped RP. It may be RP rip.
Based on this particular OCT, I don't think we will be able to say because the retinal epithelial continuity to the nasal side is still there.
We will need multiple sections to make out exactly where the rip is. But you can probably say it as a RP hyperplasia or thickening along with what looks like subretinal fibrosis clinically, isn't it?
Yeah, clinically there is a subretinal fibrosis there. So that is the reason why that is.
Tell us what is happening exactly at the fovea in the center.
Fovea, there is a hyperreflectivity, ma'am.
Where?
At the RP, just below the.
What is the main thing that you're seeing? It is the
PED.
Okay. It's a very irregular RP there, isn't it? It's not like a single PED. It is multiple bumpy elevations you're seeing in the RP, along with some hyperreflectivity, and the overlying retina is that the normal foveal thickness?
Foveal atrophy is there, ma'am.
Yes. So there is overlying foveal atrophy, and there is severely bumpy and irregular retinal pigment epithelium, which is suggestive of
ARMD.
Okay. So here, when you're, we can have two types of ARMD, no? So which type of ARMD do you think this will be? Dry type or wet type?
Dry ARMD, ma'am.
Dry ARMD.
Oh, sorry, wet ARMD, sorry, as PED is there.
What is it that tells you that it is wet ARMD in this patient? What are you seeing temporally? That fibrosis, isn't it? So
Yes, ma'am.
in dry AMD, if you had only this atrophy without this fibrosis, and if you had only atrophy there, it would be like a geographic atrophy of dry AMD. These irregular elevations are all drusen's, and it would be atrophy of dry AMD. But with this fibrosis at the thing, there is definitely a juxtafoveal probable CNVM that has then healed with fibrosis. It is not subfoveal. That is why the fovea looks okay. But just temporal to that, you are having a large area of fibrosis. So it has to be exudative for this kind of change to occur. But it is past the stage of the exudative stage and reached the stage of scarring.
So qualifies to advanced AMD. Probably post-bleed, post-scarring stage.
Scarring. Shall we move on?
Yes.
So this is a clinical picture of the right eye, suggestive of the multiple hard exudates at the macula, and left eye also there is a hard exudates at the macula.
In the foveal region?
With some macular edema in the left eye. So this is the OCT of the right eye, showing spongy intraretinal edema nasally. There is a RPE complex irregularity. There is a hyperreflectivity nasally. Entire RPE is irregular and hyperreflective, and there is a foveal atrophy centrally. There is a sub-RP hyperreflective focal.
Okay, so these are all burnt down cases. Okay. The left eye, you can see that there is a pigment epithelial detachment in the scan number 1, which is not there in the center. 1 and 2, you have that. Okay. Anyway, this does not warrant much discussion. Can we go to the next slide? Yeah. Can we talk about this?
This is the OCT image of a patient's right eye, showing a large dome-shaped elevation with which is separating the retinal pigment epithelium from the underlying Brooks membrane, and there is a homogeneously hyporeflective space, and it is surrounded by some subretinal fluid also. So this is suggestive of a PED, and because the space is homogeneously hyporeflective, we can say that it is a serous PED.
Okay, so is it an innocent serous PED, or is it part of wet AMD?
We can see a notch right next to the PED, so that is suggestive of a can be because of a PCV. The notch is usually suggestive.
What are you seeing nasal to the PED over here? I mean, you can't see me when I say that, but closer to the fovea, you can see in the clinical picture that you're seeing by the side that the PED is towards the temporal side. Yeah. The raster is showing a bit of the fovea also. Closer to the fovea on the OCT, what are you seeing there? Again, you're seeing a small PED there, isn't it?
Yes, ma'am.
Yeah. But it's filled with some material.
Yes, ma'am.
Okay, so what kind of PED is likely to be that?
That can be a fibrovascular PED, because
it can be, or it can be drusenoid PED because it is filled almost homogeneously with some material. But you told us that this one is a serous PED. So how will we differentiate a serous PED from a hemorrhagic Vara fibrovascular PED on OCT?
On OCT, mostly PEDs we differentiate based on the reflectivity.
Okay.
Serous PED, it will be homogeneously hyporeflective.
What is the other important point in a serous PED? What can you see through the PED in an
We can
OCT?
see the underlying structures.
Which structure?
The
Specifically, which structure will you see under the PED? Which membrane will you see?
The underlying Brooks
What is
membrane.
lying under Brooks membrane, isn't it? So you can see, if you can see the underlying Brooks membrane clearly, it is a serous PED. Because if it is hemorrhagic PED or fibrovascular PED, there will be shadowing, and that shadowing will not allow the Brooks membrane to be clearly visible. Now, can you tell us what kind of PED this is likely to be? Is it clearly visible? Can you see the Brooks membrane there?
Not clearly visible.
Not clearly visible, isn't it? You're seeing only that entire grayish part of the choroid you can see, but you cannot see the clear line of the Brooks membrane is not visible. So it is more likely to be a hemorrhagic PED. Of course, a hemorrhagic PED can be made out on your clinical examination. So what about fibrovascular? If it was fibrovascular, what would be the difference?
Fibrovascular, there will be hyperreflective material. It can be both hyperreflective and hyperreflective.
And hypo. So it will not be very homogeneous. It will be a little more heterogeneous. So there will be fibrovascular areas. There may be some bleed there. There may be some fluid there. So it will be heterogeneously hyporeflective. And that again, but it will shadow the Brooks membrane, and you will not be able to see the Brooks membrane clearly. So that is how you will differentiate an innocuous serous PED from a dangerous hemorrhagic or fibrovascular PED. Now, in the clinical picture, if you look, you can actually see that it is hemorrhagic, isn't it? If it was a serous PED, you will not see this black thing. The image itself will show, if you look at the clinical picture along with the OCT, you can see that the image itself is showing it is dark, isn't it? If it was serous, it will just look like the rest of the retina. So this is probably a hemorrhagic PED. So what other investigation will give us some information in this case?
We need to do an ICG to look for a polyp.
Why would you prefer an ICG over an FFA?
Because choroidal structures we can better make out with ICG, and so if there is a
Choroidal
vasculature is better made out in ICG.
Yeah. So since it is a sub-RPE damage that we are looking at, so it can be a polypoidal choroidal vasculopathy, or it can be a choroidal neovascular membrane that is under the RPE. It is better delineated with ICG than the fluorescein angiogram, which gives us more information regarding the retinal vasculature. And the second thing that is that because of the blood there, ICG will be able to give you clearer images than the fluorescein angiogram. So through the blood also, ICG will give you more clarity. Dr. Gopal, anything?
Yeah, why is it that ICG gives more clarity through blood? You talked about that. Why? Netra? Netra answered very well. Somebody was commenting to me.
Think of what should you think of? What is the basic difference between the two?
Infrared light will penetrate better in
Correct.
melanin xanthophylls and.
Excellent. So the wavelength is different, isn't it? The wavelength of the emitted light is different in fluorescein and ICG. Anybody can tell us the wavelength? Quickly.
ICG is 480. 523 to 665.
ICG 790 and 810.
Very good.
Very good. Very good.
And fluorescein?
460 to 490.
Is the
Emission
is 520 to 530.
470 to 520, we can say. So basically fluorescein is in the visible light spectrum, while ICG is in the infrared spectrum, isn't it?
okay? So this is this case in which the pigment epithelial detachment just surrounding a bit of fluid is there away from the fovea. All right, but at the fovea, we probably have to take another OCT to see how is the fovea. But based on this particular OCT, near the fovea, there is some hyperreflectivity of the retinal pigment epithelium. Maybe there is some content. We need to look at that separately. All right, next slide. Could be a PCB.
Again, this is the OCT image of a patient's left eye. Here also there is a dome-shaped elevation, which is separating the retinal pigment epithelium from the underlying Bruch's membrane, and there is the space. It is not uniformly, homogeneously hyporeflective. There is some hyperreflective area also, so it is suggestive of some turbid fluid inside, and we cannot make out the underlying choroidal Bruch's membrane also. So this is probably a hemorrhagic PED.
Actually, we need to look at whether this is a treatment naive patient or a patient who has been treated multiple times and the pigmented epithelial detachment has sort of had multiple injections, and there will be a little rough, tough retinal pigment epithelial. That surface becomes thicker. Okay, so I think this may have been a repeat injections. Basically, this lesion is pretty large on the infrared image that you are seeing here. It's pretty large lesion, and the flattening has reduced probably with the treatment. This is what I think from this picture, but as Natasha said initially in our talk, you should correlate clinically. There's a very mild intraretinal fluid. This much intraretinal fluid we may tolerate, but if this is immediately after treatment, then this is the best this patient is probably going to, the best stage of OCT that the patient is going to.
This patient is actually treatment naive.
Is it? This patient is treatment naive? So there's a large pigment epithelial detachment with more thicker RP there and some thicker subretinal fluid there. Turbid fluid.
Yes. So
again, in isolation, we will not be able to make a diagnosis properly. Probably you will require fluorescein anti-injection. Next.
This is the OCT image of the left eye of the patient, in which we can see the normal face and
not clear.
There
Yeah,
will-
you have
there
to
is,
repeat what you said.
inner nucleus. This is the OCT image of the left
Is in hospital.
of the patient and normal retinal interface and fovea at the inner nuclear layer, as well as there is disruption of the ellipsoid zone.
Okay, and what else are you seeing there? What has
ILM
happened to the
drapes
inner
and-
retinal layers?
Inner retinal layers, tissue loss is there, ma'am. Tissue loss at the fovea
So
of the
there
inner
is-
retinal layers.
Yeah, so there is foveal atrophy. The fovea has become thinned, the central fovea, and along with that, you are having tissue loss in the inner layers and disruption of the outer layers. And the tissue loss has left something intact across that. What is that called?
Drape sign.
ILM drapes.
ILM drape sign.
Drape sign.
So that is seen in
Idiopathic juxtafoveal telangiectasia.
okay.
Otherwise called parafoveal telangiectasia or MACTEL.
Telangiectasia. Mactel.
Okay. What are the types of MACTEL classification wise? Type 1, type 2, type 3, type 1.
Mactel 1, type 2, and type 3. Type 1 is unilateral and congenital. Type 2 is acquired and bilateral. Type 3 is due to some vein occlusion or vascular occlusion.
Type 2.
Type 2 is bilateral and acquired.
Okay. And what are the stages of IJT?
Type 3 is
The common parafoveal telangiectasis or macule that we see is
foveal. Widening of the
Very bad
and then
connection. You're not audible, Nia. The voice is dragging. I think very bad net connection you're having. Anybody else? Can someone else tell us the classification of IJT, the staging of IJT? Which stage will you treat? So the common IJT that we see is which type, Nia? Among the 3 types that you told?
acquired, ma'am.
Type 2B.
Acquired and bilateral, isn't
Type
it?
2.
Type
Acquired
2B.
and bilateral.
So it has 5 stages. Stage 1, 2, 3, 4, 5.
Yeah.
All right. And basically it's a stage 5, which is a neovascular stage in which you require treatment.
We have active treatment only for stage 5. For everything else, we have only
Stage 5.
Next slide, please.
This is also the OCT image of the left eye, in which we can see there is significant foveal thinning along with the disruption of the inner retinal layers.
the retinal layers are completely lost, isn't it?
Lost,
Disruption of the outer retinal layers also.
Nia, because this is the other eye of that same person, we are probably able to diagnose this. In isolation, this would just qualify as a foveal atrophy. We would not know the cause. So there are some telltale other signs of parafoveal telangiectasia in which there is a
deep vessels and there are right angles
vessels
to
at
the
right
deeper
angles.
retinal.
As well as there are some pigmentation.
Pigment clumping will be
pigment clumping as well as the migration of the RPE layers, which we can see on OCT.
Okay.
What is the clinical appearance? How will you clinically suspect that the patient has macule?
What will be the symptom of a macule? Metamorphopsia may be there, but more importantly than that,
maybe
Scotoma with decreased activity.
what kind of scotoma? What will the patient complain of?
Central scotoma.
Usually not a positive scotoma, isn't it? Central scotoma, you're saying that the patient will see black. Positive scotoma, that is seen in which condition?
ARMD.
AMD. If you have a bleed or something there, you will get a positive scotoma. But here it is not like that. What will the patient complain of? Which kind of vision will be affected? Near or distant? What is the doubt?
Near vision.
Yes. So near vision, usually patient will complain of missing letters, because that central portion there is tissue loss, isn't it? So there will be, patient will say that while they're reading, they will miss a few letters. That is a very common complaint these patients have. And clinically, when you examine, what is that clinical appearance that gives you?
Increase in the bit.
Parafoveal?
Whitening.
Whitening. Parafoveal whitening will be seen. That should immediately give you. What is the importance of, you can't treat it, but what is usually the clinical importance of picking up an IJT in your clinical examination? For a large majority of ophthalmologists, it's very important to pick up IJT clinically using your 90 diopter before you attempt
Cataract surgery.
Cataract surgery. Yes, it is one of those things that can be very easily missed in a cataract and which can change the prognostication. Patient may still have the missing of letters after the cataract surgery if you are not careful in your clinical examination.
Okay, you have to differentiate between the decrease of vision because of cataract, which causes overall decrease in contrast, color, hue, brightness, etc., as opposed to the IJT, which significantly affects some letters. In a word, they will say if there is a word called Natasha, they will see NAT. AS they will not see. HA they will see. So they will have to constantly tilt their head and start reading. All right. Okay.
Always disproportionately reduce near vision points to some problem in the macula. In a cataract, generally we expect that near vision is proportionately reduced to distance vision.
Except in PSC.
Except in PSC, yes.
Okay. Next.
Okay.
Nia, you are in theater, operation theater.
Just now got, so at 7 o'clock only it got finished.
Okay.
Yes, Meera.
So this is the OCT image of the right eye, showing the normal foveal contour is lost, and there is intraretinal edema with multiple cystic spaces, and also there is sensory neural detachment. We can see multiple hyperreflective foci also in the intraretinal layers. So correlating with the clinical picture, we can suggest that it is a supratemporal BRVO with a macular edema.
Okay. Which of the layers are usually involved in branch retinal vein occlusion in the retina?
Inner retinal layers, ma'am.
Inner retinal layers. Here, what are you seeing?
There is a disruption of the inner retinal layers along with intraretinal edema. Cystoid spaces can be seen, and there are multiple hyperreflective foci also.
Is there also something called submacular detachment?
There is submacular detachment.
Yeah, that is there. Okay. Okay.
So here these cysts, you can see that they're extending actually throughout the thickness. Both outer and inner layers are being involved in those cystoid changes towards the temporal side. The rest, this part you can, towards the nasal side, the cysts are mainly involving the inner retinal layers.
Okay, again, a significantly ischemic retinal vein occlusion will have more inner hyperreflectivity. Like a central retinal artery occlusion or a branch retinal artery occlusion will have very thick hyperreflective inner retina, and it will cause a lot of shadowing. It will not be that much hyperreflective, but more ischemia is there, more hyperreflectivity will be there in the inner retina. All right. But in the presence of edema, you cannot make out that much of hyperreflectivity. Maybe after treatment, when the edema settles down, you'll be able to see that. Next. Okay.
So, this is a clinical picture of the left eye, showing altered foveal contour with massive intraretinal edema. And you can see there is disruption of the inner retinal layers, and also the outer retinal layers are also not that much visible. There are multiple hyperreflective foci, and
The large under the retina, what are you seeing? Large submacular detachment also, isn't it?
Yeah,
so there is submacular detachment along with the intraretinal edema, and the whole thing is completely elevated.
So comparing it with the clinical picture, suggestive of a central retinal vein occlusion, non-ischemic central retinal vein occlusion.
Actually, in this particular patient, bilateral.
Yeah,
this is the same patient you are talking about.
Yes, sir, yes, sir. Bilateral CRVO.
Bilateral RBO in a case like that with hypertensive changes, atherosclerotic changes, and submacular detachments may be signaling that this is a accelerated hypertension. Very rapidly the blood pressure went
The
up.
clinical picture also looks like hypertension.
Yeah, with soft exudates and all. Yeah, so
And
this
lot of
may have been
inflammation.
secondary to a accelerated hypertension. All right. Next. This is a diabetic patient or?
Yes, sir.
Veno occlusion itself.
Yes, yes. This is an OCT image of the left eye of a patient, which shows a clear vitreous. As per this picture goes, we cannot make out whether if it is a complete PVD or if the vitreous is still attached. And coming to the inner retinal layers, we can see multiple cystic changes in the inner retinal layer, but the outer retinal layer seems to be decently intact. At points, the ellipsoid zone is a bit not visible, but that might be because of the hyperreflectivity of the inner retinal layer here. But as such, it's pointing towards a cystoid macular edema.
Can you tell us some causes which are likely cystoid macular edema?
In case he is a pseudophic, so a recent cataract surgery, history of recent cataract surgery, give with the background, especially in a background of diabetic retinopathy, let's say mild to moderate NPDR status, and undergoing cataract surgery, chances of pseudophakic CME is increased.
Okay. No, just tell us all the causes of cystoid macular edema. Again, like epiretinal membrane, how can you classify it?
Okay, then degenerative causes would include retinitis pigmentosa, because
Okay.
that is
Was that the most common cause? Do you want to put that first?
No, because while discussing that time, we included that classification, so that stuck into my head.
I put it much lower down.
Yes, so it's not at the top of the list, but yeah.
Yes, so
First
top of the list comes.
iatrogenic, maybe post cataract surgery.
I wouldn't put it as iatrogenic, but it is otherwise. What is the post cataract surgery edema is due to what?
Inflammatory.
Inflammation. So what are the inflammatory causes? One is cataract surgery. Then which other inflammation inside the eye will cause cystoid macular? Uveitis. So can anterior uveitis cause CME Mira?
Yes, ma'am.
Yes, so need not be posterior uveitis. It can just be plain anterior uveitis, which will cause CME. So CME inflammatory, one is pseudophakic, other is chronic uveitis or acute uveitis, anterior or posterior. Then other inflammations in the eye. What is the retinal inflammation that can cause CME? Comes under uveitis, okay, but some other structure that is inflamed.
Coats disease.
Okay, more than Coats disease is a generalized exudation, isn't it? Vasculitis. So if you have retinal vasculitis, you can get again inflammatory CME. So that is inflammatory. What are the other causes? What are the vascular causes?
Vein occlusions.
Vein occlusions. Both BRVO, CRVO can produce vascular causes. Then you can come bring in your degenerative.
Or diabetic retinopathy.
Diabetic retinopathy.
Then some medicines also. Prostaglandins are also known to cause.
Prostaglandins can produce, yes, drug-induced CME. Then what is the last group that is one last group that is not there in ERM classification? It's very similar. That's why I'm just comparing it to that. But there's one group that is not there. What is that called? So you can get a congenital, not congenital, but genetic. Yes. What is that called? It's called adult onset cystoid macular edema. It is genetically inherited. So that is also there.
So I want to tell you that whenever anybody asks you about any classification system, there are two things that things based on which, and you do not know the classification, and you are asked this on an exam or somebody asks you. One is, you have to location-based classification. Location-based classification can go from anterior to posterior, posterior to anterior. Come from the cornea, anterior chamber, iris, lens, vitreous, like that. You go like that to the retina, and in the retina also retinal layer-wise. Okay. And the second thing is like congenital, traumatic, inflammatory, infective, neoplastic, degenerative. So like that, etiopathogenetic classification. So think in these lines and tell in a, so in each of those, you can tell multiple reasons. Yeah. Okay. Can we go to the next
Don't
slide?
land in trouble.
Pardon me?
Don't land in trouble saying things that are not there. Yeah, use your common sense also.
Okay, next. How many cases to go?
3-4 more OCTs to be discussed.
Okay, fine.
Mainly, I think what is
Yeah.
left, I think
So
we haven't
in
covered
DR,
diabetes.
can somebody tell me who is Yash is looking at DR? So can you tell me what is the classification of edema and diabetic retinopathy? OCT classification of edema and diabetic retinopathy.
OCT based, sir, we can classify it as a diffuse type of edema, which is also called as spongy edema. Then this is all morphological. Then cystoid macular edema. Then comes submacular detachment or sensory neural detachment. Then also traction based, like retromacular traction and
Mixed pattern.
And then there's a foveal hard exudate plaque also. There could be a foveal hard exudate plaque and mixed pattern. All right. So what do we have here?
So here is a OCT of the right eye with clear, optically clear vitreous, and seems like a intact posterior vitreous face. Then nasal to the fovea, there is a bit of intraretinal edema along with this hyperreflective coagulated dots, which can be suggestive of hard exudates, especially here when there is a bit of back shadow also here.
Okay, so there are hard exudates, there is edema, there are multiple small hard exudate plaques also there, right?
Yes. The outer
more of a spongy edema with hard exudates. Foveal contour at the fovea, it may be normal, but because of the hard exudate plaque right at the fovea,
yes,
the vision may be a little reduced, maybe 612 or 618 or something like that. You cannot go better than that. Next. Okay. These are again hard exudate clumps which are causing
back shadow. So basically, this was a slide put to show that the hard exudates will usually cast shadow and are of a bigger size, more than 50 microns. Lesser than 50 microns, if it's in the range of 20 to 30, then we can talk about hyperreflective foci or dots, which are again OCT biomarker, which would, in case of numerous HRFs or numerous hyperreflective foci or dots, we can think that the pathogenesis can be more towards an inflammatory in origin and can try for steroid implants or steroid injections in that patient, attacking at the pathogenesis for the edema there. And hard exudates have to be differentiated between. So, next slide.
Next slide, Netra. Yeah.
In this particular slide, we can see that there are certain, about 10 hyperreflective foci that can be seen here, along with associated intraretinal edema. And more towards temporal to the fovea, it is looking like the submacular detachment is extending towards the periphery. It's like there can be a portion of retinal detachment towards the periphery, associated with cystoid and cystic changes in the intraretinal layer. But visual prognosis in such a patient can be decent enough because the outer retinal layer is intact.
Okay, but it's showing, say, the OCT is not very clear, but it's showing significant drill, isn't it? You're not able to make out the inner layers clearly. So that may be, and also more number of hyperreflective foci is also a bad prognostic factor.
So
but of course, we need
image quality is not very good. Why
not
is that
very
so?
good. That's right. We
Why
cannot
so?
interpret.
That is, sir, because of low signal strength.
But the graining is more.
Yeah.
Somehow. Okay.
And also
Next.
that raster, it is the upper line. It is not the middle line that has been highlighted.
Next slide.
I think that's all.
Okay, that brings us to the end. I think we have looked at somewhere around 15 to 20 OCTs, going through epiretinal membrane, macular hole, vitreomacular attractions to AMD, diabetic retinopathy, retinal vein occlusion, and cystoid macular edemas, and finally diabetic retinopathy. Right. So thank you all. Thank you very much, Dr. Natasha, for giving that nice presentation in the beginning. And thank you very much, all those postgraduates who have attended this and actively participate.